Hey everyone, Larry Nguyen, CEO at Summit Imaging here, and we have a really special guest today to really discuss some of the things that are really important to our healthcare facility customers. And this is Randy. Please introduce yourself.
Hello, my name's Randy Snelling. I work for DNVGL Healthcare. I'm the Director of Operations. I happen to be out here in Seattle with Larry. I was making a presentation this morning, a keynote speech to the Washington and Oregon Biomedical Associations. And at the end of the speech, Larry asked me if I would join him in this conversation, and so I'm here to do that. I hope it will help anybody that might be listening on this. My experience with the hospital accreditation goes back about 14 to 15 years. And when we became a deeming authority in 2008, we started doing hospitals, and now we have, I think, 26 hospitals in the state of Washington and 25 in the state of Oregon. Don't get out your abacus, but I'm pretty sure that's pretty close.
Yeah.
And so here we are. I love Seattle. It's out there behind us. And we're going to talk a little bit about ISO here and how that might help the hospitals.
Yeah.
Were you wanting to know anything about that, Larry, in particular?
Yeah, so we are working really close with healthcare facilities, especially those that have gone through a lot of consolidation and looking for kind of standardization on quality internally. And from what we're hearing, what you are providing to them is becoming really critical. And I think two audiences that you're really talking about here. One being the patient and the other one actually being the healthcare facility, users of the actual system. So, first, could you tell us about the systems that you're putting together and then how it impacts those two audiences?
Well, I can, and the system we're basically talking about is ISO 9001, and now it's 2015. For years it was 2008, but now we're 2015, and the new ISO platform is better set up to work with the other ISOs, such as the 13485 that you are associated with. We believe that the quality management system that we are bringing into hospitals, our hospitals have on their fourth survey, which is 3 full years into surveying, they are required to become ISO 9001 compliant. If they want to become certified, they can become certified, but it's part of our requirement that the hospital becomes ISO 9001 compliant by the fourth survey, which is 3 full years. That's part of the accreditation deal with us. If you don't do that, then you won't be your accreditation won't hold with DNVGL. And probably the first thing that you would notice about the ISO process after a year or two, when it's not the day we walk out with a survey all at once. The hospital has a new face on it, but the first thing that really starts happening internally in the hospitals is the silos start breaking down, because we are process oriented on our surveying, and so we all know that processes are not owned by any one department. And this is not something I think that has been easy for hospitals to swallow, or not swallow, but to adjust to. Not that they don't think it's a good idea, because I don't find a hospital that has said, oh, de-siloing's a bad idea. It's a good idea. And we're able to do this through the quality management system that ISO 9001 provides. Now, without going too far into that part of that system then is realizing that all people in the hospital own different processes. And so if we would happen to have a finding in a survey, the finding is normally written against a process, because not one person owns it. And I think the history of surveying in the United States anyway is that that's yours, and that's yours, and that's yours. And now we know, no, not necessarily, because even with the medical equipment, which we're talking about, medical equipment managers cannot work in a vacuum. And many of the processes that they have to control rely greatly on the C-suite, because they have to have the C-suite behind them. Just the notion of unable to find a piece of equipment, UTL, unable to locate. And that piece of equipment will not be found as quickly without the ISO being involved, because the ISO will require that the C-suite, if you will, or senior leadership or leadership of the organization is going to get involved.
Got it.
If we've
Yep.
got a piece of equipment, and so now the medical equipment manager can say to, and I'm just using the term C-suite broadly as we know, but it's the leadership of the hospital, that if they want to find a piece of equipment, they're going to find it quicker than just a medical equipment technician. And
Yep.
so that's just an example of one process that you may go in and you would say, okay, medical equipment manager, why can't you handle you're unable to locate equipment? This is under your domain.
Got
When
it.
really he or she is saying, well, there's a lot of people involved in this. And now in a DNVGL hospital, you've got this quality management system that says you're right. There are other people in these processes, and so if we would have a finding, it would be against the process of being able to locate this equipment, and more than one person has ownership of this. Okay, so that's just to get you along on the ISO part, and then the ISO permeates the entire organization.
Absolutely.
I mean, from security, well, I can list every service within the hospital, and they're all going to be trying to use a quality management system that checks what they do. They check for trends. They monitor what they do. They take corrective actions when it's necessary.
But I think it also fosters this camaraderie and teamwork that as you break down these silos, the focus seems to be more on a solution and resolution.
Absolutely.
And maybe maybe based off of a Kappa or a PAPA as well. And I think what we're seeing is that this is just really a step in the right direction for accelerating communication, accelerating and finding the issue of the actual, when we say process, it is literally the process, because all too often we're all human. It's too easy, like, hey, that person lost it or whatever it may be. It actually removes the names altogether and allows us to really trace and track what's supposed to happen with the equipment. And I think that what's supposed to happen with the equipment is such a great step, because if a healthcare facility knows what the equipment, where it is, what's wrong with it, or what's its perfect condition, then it finally allows for optimization of patient care and equipment use time. And so you're actually able to use the equipment that you have much more efficiently, because you know where it's at, how quick you can get there, if the functionality, if it's fully functional or if it's down, and if there is any issues there, decisions can be made quickly to transfer a patient from one facility to another to make sure they're getting to the equipment.
But with the ISO processes, and you're talking about some technical stuff there, and we're talking about de-siloing, but back to one of the ISO processes is internal audit. And I was just speaking about this, and it's funny because, well, not funny, but ironic that you say that also helps communication, because in an internal audit, and hospitals are required to do these if they are DNVGL accredited hospitals, because that's part of the requirement of ISO, is you do internal audits. So what you try to do in an internal audit is really expose folks. Let's say if you're going to audit the pharmacy, you probably would bring in folks that don't know about the pharmacy so much, because you're kind of acting like a toddler, really saying, what are you doing and why are you doing it? Why do you do that? Why do you do that? And so the person in the know has to think about this and supply this, and this is what we know. But as far as the communication goes, that person that walks out of the pharmacy now goes, man, those guys really, and those women and men in there really have to know their stuff. I didn't realize they were under such pressure. I didn't realize, well, that's why that takes that much time. Consequently, if the pharmacist would go down to the medical equipment people and be in on the internal audit to that, the pharmacist is going to go away going, wow, how do they handle? They got 10,000 pieces of equipment. How are they handling that?
It's appreciation.
And so there's
of
a
your
new,
colleagues.
there's a cross pollination, if you will, but across education of persons within the hospital that gives them a new respect for the other persons in the hospital and the staff that they have to do, and a knowledge. And if you're young enough, you may be on an internal audit and go, hey, that's what I want to do when I grow up. So, but back to your point, because this internal audit is, let's say, it is forced by the ISO standard, you do have this consequence, which is there's better education, better cross communication between departments, and also a better understanding and patience.
Yep.
Not patience. It was one going to say one guy used to say
reasonable
I was
expectations based on severity and complexity of issue. Yeah.
Right. Well, yeah, I was going to be a doctor, but I didn't have the patience.
Yeah.
You know, that kind of thing. But at any rate, that facilitates that.
Yes,
That
absolutely.
ISO and so that was just one of the things I wanted to bring up. As you said earlier, we could talk about this all day long, and I'm trying to keep my own thoughts and talking here within confined space of the ISO and what that means. Now, we're talking about medical equipment here and the management of medical equipment. And so when we go into a hospital for the first time, there's only one group of people in the hospital generally that can spell ISO, and I mean that in a good way, but that rub elbows in the ISO world, and that's the medical equipment technicians and managers and those sort of things. They can speak ISOEs because at least they know the 13485. They see their equipment is ISO certified, and much of that, you know, and so when we go into a hospital for the first time, I won't say push, but we really go in and talk to the medical equipment managers so they get an idea of the types of things that they're going to have to do within the ISO world because they're first. And this is going to take 4 years. This is going to take 3 visits. And so we want to give the medical equipment managers a jump start on the ISO because they're going to get very involved in this. So we can't wait till the 3rd year and go, hey, guess what? You need to have traceability and be able to track this. You need to have, you need to be able to trace your equipment to NIST. You need to have certifications of your equipment that mean something. That when you send a fluke meter off to be calibrated, that when you get that meter back, if it was out of calibration, what do? You just go, oh, well, that's too bad. No, you have to go, oh, where's that thing been? And how do I track that? And that's
and
all
what
part of
equipment
it.
was it testing prior to
Sure,
that
absolutely.
to then take a properly calibrated meter and then go reconfirm those tests to
Right.
make sure that those aren't out of calibration because your calibrating equipment was off in the first place.
Right, and we run into this a lot, so we get this question a lot, and which is, how far do we go with that? And our answer always is, because we consider the people in the hospitals the expert, is how far do you think you should go? Now, the idea, it's perfectly acceptable to take a sampling. And so you start with that. You know, you sample what you got, and if you get a sample, a scientific sample to your liking and to different risk assessments, then you can move on with it and say, this is the way we did this. But the thing that is you don't wait till you get that fluke meter back that's OOT, out of tolerance. You already have this process set up.
Exactly right.
So that you are considering when you're doing your equipment maintenance with a piece of equipment like a fluke meter, that I'm already thinking, I may have to trace this. When we send this off and this meter would come back out of tolerance, I'm going to have to know where I was.
Exactly right.
And so there's
Interesting.
that.
Yeah, we've seen so much of improvement, and I just want to thank you for helping just drive quality, and we just want to continue to help in any way that we can, and I think our audience here is going to appreciate you sharing your wisdom and your expertise. And
I don't know about all those accolades, but go ahead. It feels good.
And we see the same thing in the medical device independent service space as well. And for us in the 1345, kind of a different application of an ISO system, but.
That's interesting. You mentioned 14385, and because I'm sure that all your listeners or whatever know what that is. That's the ISO standard for manufacturers of medical equipment, and that is one step beyond what we look at on surveys. In other words, we're not going out and surveying a vendor or a manufacturer or whatever. But when it comes to 1345, and DNVGL has people who do this, we're out away from the hospital in another environment. Now, You might say, well, what's the connection then? Well, the connection is in all ISO processes, you have to get feedback from your customer.
Mm-hmm.
All right. And so I'm not going to sit here and make a claim that there's a failure of this or a failure of that, but I have noticed trends in my years of doing this where I hear hospital techs and whatever say, we have given feedback and there's been no response. But I don't have any empirical evidence that says this is the hospital that did this and this is the hospital. I just know from listening and going to different medical equipment conferences, as I've done over the years and spoke at them, that I hear a frustration of that group saying we're not being listened to by the other group. The 9001 fellas and women are not being, maybe their feedback is not necessarily important or being interpreted by the manufacturers. But before everybody starts throwing tomatoes, these are trends that I've heard while I'm in the hospitals, and it occurred to me that if this is really trending, then the auditing of 13485 ought to take that into consideration if they're not. Maybe they are. Are you getting, if I was auditing the OEMs, I would say, tell me how you've changed things, how you've documented your feedback, who do you get feedback from, what have you changed, what have you refused to change because you don't think the feedback was accurate or well developed or studied through, these sort of things. So I don't want to step into what I don't know much about, which is the 13485 standard, but I know about ISO, and I know we have to communicate with one another, and I know that I have heard many anecdotal tale that there's not a feedback and a communication there. So that's what I've got to say about that. Now, do I think that all ISO processes are valuable? I think that like the 13485, without the 13485, you may have a vacuum that would end up with the harm of patients. Even with, I mean, patients may be harmed now because equipment failures and things like that. I'm not going to delve into that. I think the empirical evidence shows that there is a certain amount of patient harm due to all kinds of things. You know, whether it's cross-contamination, whether it's the wrong humidity levels in the operating room, or even to some medical equipment failing. So there's a lot of different processes to follow up on that. One of them is the medical equipment, and are we trending with anything that the manufacturer should know about? And so I would say that the absence of 13485 in the OEM world of medical equipment might set us back to the Wild West if we aren't, you know.
Exactly.
So I'd have to endorse the fact that that the manufacturers are trying or complying or trying to comply. You know, I'm sure just like everything else, some people do it better than others. But if I were an auditor, I would still, I would think it was important, the communication that we have as manufacturers with those that are using the equipment. And then you go one step farther, which is the equipment maintainers in the hospitals. Like I said, there is a thought in hospitals that the patient is the ultimate customer, and that's true in the ISO process. But in any ISO process, you have internal customers. And so inside the ISO process of a hospital, the medical equipment managers, their internal customers are the clinicians, the doctors and the nurses and the other skilled people who are using them. And that's where they should be, in my opinion, the medical equipment people in hospitals should not hesitate to be getting that feedback from the clinicians. And if the clinicians are not cooperating, then guess what? The C-suite's got to step in and says, this is the way this all works.
Exactly.
And this is how we communicate.
And I think that organization, you know, as we kind of look at the ecosystem of, you know, for our optic is from the independent medical device, you know, service and support side, and then we support hospitals. the 1345, connection to the Hospital 9001 provides a foundation to continue to move forward and to improve. And I think that's something that both 9001 and 1345 are absolutely in places to continue to improve. And it's actually baked into the processes and the systems themselves. And what excites me about that is that I think there's room for improvement for everybody to communicate quicker, for the whole market to become optimum. Because right now the communication is a bit broken sometimes. It maybe lags or but it's at the end of the day, it's all about the patient and how quickly can we all help them is the most important thing. But
yeah, and it's an easy thing to say, and not saying that you just said an easy thing, but whenever you go into a hospital, listen, 98% of people that work in hospitals are there because they love their fellow human being.
Yep.
All right.
Absolutely.
And they want to do the best thing. It's like I always say, the other 2% are serial killers, but but 98% they're wanting to be there. So there's this want to do the right thing for the patients, but sometimes the patients aren't the only customer.
Absolutely.
And although that's how we're supposed to look at it, but there's a lot of issues in treating patients that are not known to the public. And there's a lot of processes that like surveyors see behind the scenes, and there are certain processes that if they're broken or non-existent will hurt you in the long run. One of them being, again, like the unable to locate equipment is if you've got, hey, we expect 100% of the equipment to be found, and we can't say that we don't, because where would we be if we say, when I got in this, the average was 95%, man, that's good. We're finding 95%. Okay, that is pretty good. But you still have to account for that other 5%. What's going on here?
Exactly.
You don't want to put that on your hospital's brochure. We can find 95% of our equipment, and so the goal is, the process is to do 100%. And if you can't do that, that's okay. You document the trend or the shortcoming that you're having.
Because the documentation provides opportunity to learn. So and the learning piece is really critical, and that's where the improvement comes from. And
well, Larry, without documentation, there's two things you can't do. First of all, you can't teach anything.
Correct.
All right? You can't teach error. You have to have it. And the other thing is you can't improve it.
Correct.
And so we're all about improvement. And it's one of our ideas one of our founders' ideas was that coming back every year, we now become an instrument in the process of continuing improvement process of the hospital. 3-year surveys are fine. They're fine with CMS. They're fine with other deeming authorities. But we feel like there's a 2.5-year exhale after the 3-year survey, and we did not want to allow for that. And we wanted, the original idea was that this survey, which seemed to, the surveys when I came involved were built around consternation and confrontation. And a lot of things weren't being found out in surveys. So what we're trying to do is be part of the continuing improvement process, and you use this survey as one of your steps. But I know we're wanting to talk about ISO, so I won't get around telling you, let me go, and we'll just sit here all day long. So
well, I think what we're kind of continuing to dance around, and I think I can speak for you here to the audience, is that all of these quality management systems, whether it's 9001 or 1345, does a couple of things for total cost of ownership. Number one, allows us to all run more towards optimum to save on costs. But number two, I think for everybody involved, it decreases liability for the healthcare facility itself.
Absolutely.
And so I think that liability variable of total cost of ownership is significantly reduced. And I think that's just a really safe and a really terrific approach, and it's a multifaceted win at that point.
Well, what you're calling liability, I might call risk.
Yes. Yep.
And of course, we concentrate on hospitals now, especially with the 2015 ISO, is for them to identify their own risk areas.
Yep.
You know, what is our risk area? Now, when it comes to medical equipment, when we first go into a hospital, the risk areas would be you're unable to locate. How do you communicate with your clinicians that this piece of equipment may not be maintained? Some hospitals, most hospitals, use a sticker system. We don't require that. When we go into a hospital, they're the experts, however they want to do it. And as I've said many times, the only real wrong answer is when we ask a question is when the hospital person says, "Say what?"
Yep.
So
Fair
that's
enough.
when we know there's
And
not
that's
a
where I
process.
think that risk piece comes into play.
And so you identify your risks. For instance, this morning I was talking about cross-contamination. When we go into a hospital, we're wanting to know from the medical equipment operators, how are they warned if they're going to be working on a piece of equipment that has been contaminated. Now, a hospital may have several different ways of handling that, from the clinicians taking care of the cleaning to but the most important thing is we just can't go on and say, oh, we don't have a process for that. It's hit and miss.
It's thorough, and you know, thoroughness, it's going to grow.
And I just want to point out something else to you, Larry, not to interrupt, but when we first went into hospitals, when I first started doing this and going into doing medical equipment managers, a lot of the things we were saying, they were like, what? You got to be kidding. The traceability on calibrating equipment stuff, I had people fall out of the chair on me. Yeah. And then when I would come back the next year, the same person would go, I can't believe we weren't tracing that equipment. You know, how could we have done
that's
what
where
we
that
were
improvement
doing?
comes in, and with the improvement, and you know, especially you kind of get a huge chunk of risk removed just by implementing the system, and then the risk is continually perpetuated in its reduction the longer you run it, because you get better at running the system. And so, you know, I just wanted to say thank you so much. You're such a wealth of knowledge, and I'm sure the audience, if you want to reach out to Randy, he is more than happy to, you know,
Find me
field
on the
questions.
internet.
Yeah, find him on the internet.
DNVGL Healthcare.
We'll throw his information in the comments below. But if you like what you saw, you learned a lot today. You know, we certainly did. We just want to share it because we've been asked to by our healthcare facility customers. You know, subscribe to our YouTube channel, like us on Facebook, follow us on LinkedIn, and until next time, thanks so much for watching. Bye.
Thanks, folks.